Okay, I'm going to begin. Thank you all for attending our peer learnings with our ACEs Aware collaborative. We hope today's peer learning will help you address those most challenging concerns that may arise when administering the Pearl screen. At the end of this session, we'll share additional resources available to support you through our collaborative, as well as a short evaluation that we'd like for you to complete, which includes a gift card. As you know, we'll be recording today's session. And before I begin, I'd like to remind you to please mute your speakers, put your screen on speaker view, which is at the top right corner, and please put your name and your site in the chat, along with any questions you'd like for us to address in our Q&A at the end. We are a collaborative of First Five Alameda and Contra Costa County, UCSF Benioff Children's Hospital, Center for Child and Community Health, the Medical Home Project at Stanford Children's Health, and Dr. Renee Wachtel, Developmental and Behavioral Pediatrician. Through the ACEs Aware Initiative, our collaborative will offer you many resources curated through us at the Medical Home Project, along with access to services for children and youth with special healthcare needs via our monthly TA and outreach, now by way of our newsletters to you, our pediatric partners. So think of us as an extension to your referral desk for resources for children 0 to 5 and those with special healthcare needs. My name is Lorene Perret, Program Manager with the Medical Home Project at Stanford Children's Health, where we partner with Help Me Grow of Alameda, Contra Costa, and San Mateo counties, and Child Health and Disability and Prevention of Alameda County to promote developmental and trauma screening programs for pediatric providers. We also promote child health and development with linkages to resources throughout the counties to better serve children ages 0 to 5 and those with special healthcare needs. Today we have, as part of our moderator, Dr. Renee Wachtel, a developmental pediatrician with UCSF, who will be presenting a clinical case study along with our guests. Shelley Hamilton is a licensed clinical social worker and is the manager of the Center for Child Protection, a subspecialty medical department at UCSF Benioff Children's Hospital, Oakland, whose mission is to care for maltreated children and families and to work actively to decrease the prevalence, recurrence, and escalation of child maltreatment and family violence within an environment of respect and sensitivity. She joined UCSF Benioff Children's Hospital, Oakland in 1995 as medical social worker before transitioning to the Center for Child Protection 2 years later to provide comprehensive psychotherapy services. In 2001, Ms. Hamilton began her tenure as the manager of the department where she oversees administrative and clinical services while still serving as a psychotherapist to children, youth, and families. Ms. Hamilton received her Master's of Social Work degree from the University of Southern California. Over her 30-year professional career, she is most proud of enhancing and expanding evidence-based treatment for childhood trauma to disenfranchised communities. Karen Bohal Ortega is a licensed marriage and family therapist and the ACEs project lead at Support for Families based in San Francisco, who specializes in working with children and families impacted by disability and special healthcare needs. As project lead, she is working to highlight the prevalence of ACEs within the disabilities community, as well as considerations to improve comfort and build trust within provider and family relationships. Karen holds a Master's of Arts in Community Mental Health from California Institute of Integral Studies, San Francisco, and is a certified trainer for strengthening families, protective factors, and social emotional foundations for early learning. She is a proud mother of a 5-year-old who continues to enhance her perspective on parenthood and challenge her approach to this work. Okay, Dr. Wachtel, why don't you take it away?
Thank you, Lorene, and greetings, everyone. What I'm going to be doing is presenting a challenging case of a patient that I saw recently, just to set the scene for what we're going to be talking about today. So I'm going to use just the initial M for the patient. So M is a 31-month-old female who I saw accompanied by her mother. And her mother was concerned that M is delayed in her development since she was late in walking and late in talking. She's also concerned about her behavior. M has temper tantrums, and she can also be very violent, hitting, kicking, and cursing when she gets upset. Her mother wonders whether she might have autism, since two of her brothers have autism. M is afraid of loud noises, and she's afraid of yelling. She is a bully with her brothers, and, according to the mother, and she pushes them away or fights with them. She does not share anything with them, like toys or snacks, and she wouldn't comfort her brother, one of her brothers, if they cry. She has temper tantrums 3 or 4 times a day that last up to 5 minutes, sometimes longer, and mostly occur when she's told no. What the mom tries to do when she has these temper tantrums is to keep her safe and then ignore it. But father often yells at her and sometimes at the other children. The M has been exposed to domestic violence in the past. The mother herself has a history of anxiety, post-concussion depression, PTSD, learning problems, epilepsy, and she herself was in foster care because of prenatal drug exposure. So she has a very complicated history herself. And there are 2 siblings that M has, both boys who are 12 and 7 years old, and both of them have autism. So obviously this is a challenging case, but not totally unusual case for what I see. And when the mother of M completed the pearls, M had an ACEs score of 4. So there's obviously a lot of further evaluation and referrals that we would consider for this situation. But I thought it would be a good idea for us to get more of a background about how to evaluate this from the pediatric point of view, and also how this would be best received from the parent point of view. So Shelley Hamilton is going to start discussing this from a pediatric point of view.
Good afternoon, everyone, and it's a pleasure to be here to talk with you just for a little bit about this really important work that we are striving to do. And again, I am a licensed clinical social worker at the Center for Child Protection, and we have worked with so many families over the years around issues of maltreatment, but especially around issues of corporal punishment and discipline. And as we kind of work to kind of figure out how to proceed with implementing all of the recommendations regarding these surveys, one of the things I think we first must stop and just really acknowledge is that they're really broad concepts about, increasing safety and resiliency in children. But I think we have to acknowledge, what does that really mean? If we're honest, most professionals don't pick up the survey and look at the screening survey, see that there's 4 indicators there, and then say, I know, now that I have this survey, I know exactly how to help this family. And if we also are honest, we are also looking at what are those referrals, what, the kind of sometimes the quick fix that we can do to kind of help our families. And at the end of the day, where we must start is just having conversations. We have to have conversations. This is when we as providers really must adopt a trauma-informed approach. We as professionals must really combine cultural humility and relational health principles in developing the ability to translate and communicate the intersections between historical trauma and the research on child development the effects of physical discipline or exposure to violence on the developing brain, the connections between family violence and racial disparities in healthcare and in education, and in other sectors of our community, such as foster care and the juvenile justice system. And we have to do this all while trying to offer some healthier parenting practices and alternatives to these really diverse families. And as we proceed with this, we have to really acknowledge some things as well as providers. And the first one is that in order to have cultural humility does not mean that we are colluding with a family that uses physical discipline that we have determined that have been harmful. And we also have to acknowledge that we have to have these conversations. And sometimes there are conversations that we deem to be uncomfortable. Many of the conversations are about kind of our families and cultural attachments. Just like within this case example, we talk about what might have happened in this woman's family as she was growing up. We have to understand the nuances that a lot of families come in with what it means to have these kind of core pillars of what they believe to be responsible parenting in our society, and sometimes in our very racist society. We have heard, for so many people, talking about the nuances of raising a Black child in America. And we have to understand, how do we incorporate these discussions as we're trying to understand how to proceed in helping a family like this. And then we also have to kind of assume that families are not necessarily resistant, that they actually might be invested in understanding ways of integrating healthier alternatives into the parenting process. So in a case like this, one of the things I often say is that as a good practice for all of us, and I tell this to my clinicians all the time, is that we ourselves must first adapt kind of the trauma-informed principle of mindfulness. We have to understand kind of how we are as beings before we even enter into the room, and just doing a scan of ourselves, of our body, to understand what might we lead with. If we understand my face is tense, or I might be clenching my jaw, we have to understand what might that do to the relational dynamic with our patients. And then once we're in the room, we have to really focus on engagement. For a mom like this, we understand all of this history. We have to start with, how are you doing, Mom? And really try to understand what's happening for her in this real time. The concerns are all over the place. We have to always assume a couple of core things. That first of all, if we are worried about a child or family, there's a very good chance that this parent doesn't feel supported. So we have to always remember that factor. We also have to remember that most of these parents are really trying their best to be a good parent. And so we have to really kind of look to see kind of how can we expand and how can we support that dynamic. These surveys give us a wonderful snapshot, but now it's up to us to get the bigger picture. And we start again by asking questions. We ask, and we have to remember, it's really critical about even how we ask the questions for these families. Are we coming into the office and looking directly at our computer? Are we asking questions in a way that kind of says we really don't want to know? I shared with someone this week that I had my annual GYN appointment on Monday, and my provider has for a long time incorporated a policy of screening for domestic violence. But the way the question was asked of me was, so you're not worried about safety at home, right? So for me, I wasn't, but what if I was? Did I feel safe in really addressing that with my provider? Did I think my provider was really invested in understanding kind of what I needed? For this case that was kind of just discussed, we have to kind of really kind of rely on kind of those core fundamentals of really assessing kind of just basic needs of our family. we always kind of say, start with the kind of the three questions, exploring about, what are the concrete supports that are available? What are the social supports that are available to a parent? What family and friends do you have? For a mom like that, this would be a really critical question. Who's supporting you, mom, in this process? And do you have a place where, in terms of a community support, do you have a place where you belong? For a parent like this, I think it's for someone who's have young children or who's especially a first-time parent, it's great to get an idea to ask them about their childhood. For this mom, we have a snapshot of what her childhood may have been like. And it's a great idea to ask them about their childhood with the aspects of, from a parenting standpoint, what really worked well for you in your childhood? What do you think worked well? And what are those ideas are those things that happened in your childhood that you would like to change, that you would like to steer away from? I think we have to be really mindful of labeling things as bad parenting, anything that can be judgmental or have some bias, but really allowing the parent to kind of reflect on their childhood and then understand kind of those ways that we can kind of help them enhance. We talk to them about, tell me about what you need. And we can also just, really understanding. And I think that's a really big, really important part. I think we get so focused on that, of this is the referral that we need to provide, but we have to start and say, Mom, what is it that you really would need? What's really of importance? What's going to help bring some relief, address your most immediate concerns, provide you a sense of support. And that really shows that attunement for our families. And then we kind of proceed with kind of a tiered approach. We work with kind of a strength-based approach. We look at those concrete resources that might be of a support for a case like this, for example. Then we might move to a relational health standpoint, where maybe a relational mental health standpoint might be a need for referrals for kind of early childhood mental health services, for example. And then there are some times where we get these surveys and we look at them and we realize that there might be a concern regarding mandated reporting. And sometimes people say, well, how do I bring that up? How do I talk about that? We talk about it in this very same format. We still start with a kind of a relational based model, the same thing, kind of the same flow. Tell me about what's happening for you. Tell me what's going on. And then having really authentic discussions about, this is where my concern is. And the law is fairly clear in terms of our responsibility as a mandated reporter. If we have reasonable suspicion that a child has been a victim of abuse or is kind of at risk, at a high risk for abuse, then we're mandated reporters, and that's based upon reasonable suspicion. But it's the process of how do we have these discussions with families. In all of my time in the Center for Child Protection, I think I could probably count literally on one hand when I've had a parent who really got upset with me about mandated reporting. And that was really, that's really unique, because I think people think the opposite. I think they think that there's going to be this immediate kind of response. But I say, if you lead with kind of, just developing engagement and having these conversations about why you're concerned and really trying to understand their perspective, as well as you listening to what's happening for them, I think we can do a lot to really kind of provide psychoeducation and help families understand kind of the stance. We also have to, in that process, I always acknowledge kind of the cultural concerns. We know that, unfortunately, for so many of our families, there are real concerns about kind of the the criminal justice process, the system. We have to acknowledge that there's biases in mandated reporting and just kind of the landscape, unfortunately, that's happening in our world as we speak. And so we have to have a place to hold that space and really be able to talk about the concerns, with them. But I think, if we are mindful of this process, we can have this discussion about kind of a very difficult process, um, and really kind of help inform decision making. I always say, let's start with kind of asking parents also, how can I help you? How can I support? How do you learn? What would be most beneficial for you? And then what we do is start to kind of make a plan. Now, if you're in an integrative practice, hopefully you have a mental health provider who can be of support to you and can help pull all of those resources together. But if you're not, this really stresses the importance of really building a resource network so that you can provide resources and guidance for families like this. Working, understanding what agencies are in my community that I can work with. In the Center for Child Protection, for example, we interface with our community providers all the time who say, this is what I have in my happening in my office today. Can you help me understand how to proceed? And just having that engagement, or doing a warm handoff to be able to talk to a parent in more depth about, about discipline or about the exposure to domestic violence, in their home, about resources that are there. But let's talk to parents about, again, how would you like to be connected? One of the things I've been really encouraged about is just the diverse options that are available to work with our families. For example, there are tremendous websites that not only are a great support for the providers, but for parents as well. Networks like National Child Traumatic Stress Network, where you can, put in, I am the professional, I am the parent. I'm interested in parenting resources, for myself, for my patient. There are virtual support groups that are out there on so many different topics, not only for the parent, but also even for the kids. There are so many that have cropped up for pre-adolescents, for teens during this process. We look at everything from apps, that can help reinforce kind of parent and child psychoeducation, social media sites, YouTube videos, books, a lot of different type of resources to to address kind of some of these issues. But again, having the discussions about helping parents understand why you're concerned about kind of a disciplined approach, if it's for hitting, for example, and understanding kind of why their kind of thoughts about exploring about hitting, for example, that comes up quite a bit. And sometimes we kind of have to also understand that it's rooted, again, in this historical trauma. So we have to really do a great job of peeling the onion, if you will, instead of just kind of, announcing it as, for example, a bad strategy and going from there. I'm going to stop there because hopefully there will be some, parts in discussion, but that's just a really kind of a grand overview about kind of just the process and just acknowledging that it is a difficult kind of field to kind of hold all of this, all of these kind of challenging issues. It's not an easy fix, and it really evolves around us having these very purposeful conversations that sometimes can be quite difficult.
Great. Thank you so much, Shelley. Dr. Wattel, I just wanted to share that we are starting to get some questions in the chat. And I just want to let the folks know that we will be addressing those questions toward the end of the Q&A. That's okay? All right, thanks.
Okay, so we're next going to ask Karen to give us some of the information that she has received from parents. I know that she's had some focus groups with parents about this whole issue of screening for adverse childhood experiences. And I'm really looking forward to hearing it from the other perspective of how does the recipient feel, and how can we do the best possible job of forming the support with parents, which is the purpose of this whole thing.
Thank you very much for having me today. And what's so interesting is, Shelley, props. We didn't coordinate, but you said so many things that actually really resonated with families. And so your folks are going to hear some very similar statements that I bring out today that were extremely crucial to the process. I mean, this is about relationships. Relationships is how we become more comfortable in being vulnerable. So Shelley was on point. So as far as the voice that I bring, I'm the ACES project lead at Support for Families in San Francisco. We have been working with different families of children with disabilities and special health care needs. We've been trying to gather input on kind of the prevalence and the impact of ACEs, as well as their perspective on intersectionality. Shelley hit on that as well when she said, there are layers to this. Families have identities, and identities definitely impact how they receive a screening, how they receive conversations and interactions with folks who are in positions of power. When we are a medical provider or a clinician, we are in a powerful position. So that's something that we have to consider as we move through it. We were looking at how do we use existing systems within the disability community, whether it be the 5 protective factors, which is very strength-based, whether it be person-centered planning, also strength-based and centered on the person, and then navigating systems. And really looking at how to enhance trust, build comfort around discussing trauma, which is a very uncomfortable thing. But the hope is through the rollout of ACEs and PEARLs that we can start making the uncomfortable be a bit more comfortable to get families linked to the services that they really need to be their best selves. So how do pediatricians, how do service providers develop quality relationships with families? And also, I think hand in hand with that, how do we enable parents and caregivers to feel that like valued partners in the process? So my hope is that any pediatric care or support services, that the notion of relationships is at the core. Relationships, they drive the work, they require connection, they require understanding. And this is actually the first step in healing. So you're giving a screening, but you're actually creating a relationship that is a healing type of situation for a family. So don't think the work starts after, the work starts when you start this rollout of a screening. And I want to emphasize that because healing is the ultimate goal, and it starts with you. It starts with the way that you roll out, the way you engage with these families. And then I pointed out the power balance. There is a power balance innately when a family comes into your office. You are considered someone who can kind of dictate a lot of things for the family, whether it be their health or the follow-up after the screening. So I always want to be conscious of that, is there is a power balance, and how we engage begins to shift the balance a bit so that families can be thought partners in this and not just someone who is having something done to them, but something that's happening with them and with the provider. Something sat with me the other day that I wanted to point out is, if we only knew what was in the hearts and the spirits and the minds of what's happening with families, that curiosity position of saying what's happening with them, especially when we're talking about trauma, not what's wrong with the family, but what's happening in their lives and the context of their lives. And our goal is to create a situation where families feel comfortable expressing that, because a lot of the families that we talk to in the work that we've done is they said, unless I feel comfort, you will not know what's happening in my life. I will tell you what I think I need to tell you because I need to fill out this form during this appointment. But the way that we set up a situation with families definitely increases the vulnerability and the honesty so that we actually know what's happening in their lives. All right. So some of the things that came up, and I want to point this out because I'm speaking very closely to the disability community special health care needs, is the complexity of a family situation, especially when we're considering disability, absolutely impacts so many layers of what they need and what they'd like from providers. It impacts the depth of relationships, continuity with providers, coordination of services, time. Time is huge. Time, not just in the appointment, but face time with a provider. And then just simply what's discussed at appointments. How much face time is given to discussions around services, how much face time is given to discussions around trauma. So what families ask for, and Shelley used this word, authenticity. Families want to feel that the provider cares and has concern. There's a warmth. There's not alarm necessarily, because alarm can be a very scary thing for families, but there's concern and compassion. When I was collaborating with a pediatrician at UCSF recently in San Francisco, they said, they gave me this example, because I kept saying, we got to lean into our compassion. We have to really understand and feel and be with families. And she said, in med school, I was taught if someone is coding or someone is in an emergency situation, I got to turn it off. And I have to work on these steps to save their life. And she said, it's completely the opposite of what I've been taught, to then bring my emotions into it. But when we are asking families to be vulnerable and to talk about the things that are deep to them, that have impacted them in so many ways, we do have to kind of go out of our comfort zone and lean into that compassion a bit, to create that warmth, to create that situation of concern, so that we can engage with families in a way that feels safe and that they're honored and they're heard. Families talked about really wanting to have people say, like, how are you? Shelly mentioned that too, like, how are you, to the parent, to the caregiver, what's going on today? If a family is late for an appointment, not the assumption that they didn't want to get there, but I wonder what happened on their way to the appointment. I talked to a family that their child is in a power chair, and the Muni bus broke down. And when the Muni bus breaks down, at least in San Francisco, I'm not sure about the East Bay, nothing works. The lift for the wheelchair didn't work. They sat on that bus until a technician came out to fix the bus. They were late for their appointment. So there's so many things that come into play that we don't know about sometimes. And so simple questions like, how are you today? What's going on? What happened on the way here? But those questions, when we ask, that aren't on a form necessarily, but are that humanity, that question between us, how are you? Those are all important. And then listening, not looking at the computer, but really listening and hearing what they have to say in a way that maybe we have a follow-up question. Something that sits with me a lot is, one of my go-to questions is, tell me more. Someone says something to me, tell me more about that. And even if you only have a few minutes, if you spend those few minutes wisely, you will get so much more from a family because you built that comfort. It's very similar to when we enter a meeting with colleagues or with other professionals. When we have an opportunity to do a quick check-in, that's not on a form, that's not a task on a list, but that is a way of relating and building that connection, we will settle into that meeting so much more and open up a lot more than if we just dive into the tasks and dive into that checklist. So families really wanted that authenticity. They wanted that conversation. A lot of them said as soon as someone brings out a piece of paper or turns to their computer, they've stopped giving accurate answers that are honest around hardship. But if you have a conversation, it definitely will shift things for them. Continuity and coordination, I have to bring that up because especially when we're thinking about complexity of disability and special healthcare needs, our families are seeing so many providers. It's key. Continuity is key to comfort. When someone gets used to you, gets used to your process, how you roll things out, gets used to your waiting room, knows what's happening, they are much more likely to feel comfortable and to share. A lot of our families said that, especially around trauma and ACEs, if they are bouncing from provider to provider, they have a very hard time because not only are they expected to retell their story, it's re-triggering. Every time that they then have to go and say, this happened to me, yes, I've experienced this, it brings feelings up for them. And especially because historically there have been situations where providers haven't read their chart. They've gotten referred to someone else, and the providers have acted as if they didn't know even what the family had been through. And so reading the chart is key if you're getting a referral. And secondly, understanding that families might be reluctant to share right away. Coordination of services, a lot of our families too mentioned, well, what if I tell them this on a screening? Okay, then it goes to someone else, and then they're going to offer me something, then this one offers me something. How can we work together to make sure that one person is taking the point, this one person is going to offer this, or that we're all talking? so the family isn't feeling like they're getting referral on every end. So that's something is just really keeping in conversation with the folks working with families, with the family themselves. What do you want? What to be your best self, to bring what you need to the family, what would that look like for you? And I think that's a power shift too, when we think often families might come in saying, yes, you are the expert. Absolutely, you are the expert in the medical field and healthcare. And families are experts too. They're experts in the lives of their children. They're experts in what they think their family can handle, can bring forth in a plan. So it's important to really look at that power too. Time was huge. Families talked about if we had just 5 more minutes in an appointment, what could we do with that 5 minutes? Could we spend a bit more talking to the family? As Shelley also pointed out, there's generational trauma. When there is trauma existing for a child, often there is trauma that existed for the family, especially when we're looking at historically oppressed communities. There are layers and layers of this. And so we have more than just the one trauma. If a child scores high on a PEARLS, chances are a parent probably scored high on the ACEs questionnaire. So we have to consider that. And if we're going to support a child, we have to support the people around them. And so giving that extra 5 minutes, dedicating it to the family, asking how the caregiver is doing is crucial to really making long-term change, because if the family can't heal, the child won't heal either. We can't just do the services for the child, it has to be for everyone. Some of the families brought up the idea of what if there were biannual appointments that were just for the caregiver? And what if the child had another place to go where they didn't have to be in the room? Talking about this trauma in front of your child, that's challenging. It brings up a lot of failures as a parent and a lot of fears. And it's not best practice. So how do we give the children a safe place to go so a family can feel vulnerable enough to have these types of conversations? And then, like I said earlier, the expert piece, saying simple things like, I trust you as the parent. What do you feel would work for your family? What would you like to see for your family? That question around, like, in a best case scenario, if these barriers to this wellness or health were removed, like, what would you want for your family? Those are really inspiring questions, and they also put the expertise on the parent. And that will help to enable parents to feel like valued partners in the relationship. So another one is, how do pediatricians make a family feel safe? I kind of touched on a few of those already, but just knowing that it takes time. You know, if you see a family for the first time, chances are they might not tell you everything that's really happening. Someone brought up, I think on last month's call, don't do a screening once, do a screening when you meet with them annually. Do it more than once. A lot of our families talked about the first time potentially doing a de-identified screening. Once they've seen you a few times, then do an identified screening. See if we can then kind of get a bit closer to exactly what's happening for the family. But to have an expectation that a family is going to come in the first time and tell you, yes, my child experienced sexual abuse, especially because that one, right, our flags go up and we say, uh-oh, do they still have contact with the child? Do I have to call CPS to make sure that they don't? We know all the things that come along. A family, chances are they probably know that too and are going to say, nope, that hasn't happened. So really considering, how do we roll it out? How do we become flexible with our plans? Like I said, do we start with a de-identified, and then once we've seen them enough, then we do identified? So considering those things. And just continuing the process, because the more that families are asked these questions in ways that feel compassionate, the more often that they are the likelihood of them being more honest and more vulnerable in the long run will absolutely increase. We want to create comfort around discussing trauma, normalize trauma. It happens more than we talk about it. And the more that we create comfort and normalize it, the more likely we are to get honest and very vulnerable answers from families. Last, in terms of other ways, this is a basic one I go to as a clinician, is has a family's basic needs been met? When we start to talk about trauma, physiologically, a lot comes up for families. I often see families who you can tell their heart rate's up. You can tell that they start to seem parched. Have I met the basic needs? In my office, do I have access to water for a family? Are they hungry? How did, do they have a place to sit, or are they standing? That physical space too. If any of the ACEs involved violation of someone's body, how small is my space? Can I administer or have these conversations in a larger space where I'm not right next to the family where it might feel confining? Our families talked a lot about environmental situations. I think part of it is because environmental barriers, when they think about the disability community, that happens so often, that there are things that are set up that aren't universally designed to accommodate folks with disabilities. So environment is on our mind. Is the space small? Does my child have a power chair and we're all stuck right next to each other talking about trauma? I myself would get a little bit nervous around that. So really physically, if we are administering these screenings and we're having these conversations, is our space large enough? Do they have a cup of water? Are their basic needs met? And then how do we help families not feel criticized when we talk about these things? Something that I want to point out is, especially because I come from the lens of working with the disability community, ableism runs deep. Ableism is prevalent everywhere. It's the environmental barriers, and then it's the stigma. A lot of parents carry around shame and blame, believing that, especially, I think about autism as an example, because of that study done years ago that said if you vaccinate your child, they are more, which the records were falsified. Like, parents sit with that shame of, if I hadn't got my child vaccinated. Things like that are based on myths, but that doesn't mean that the family doesn't feel it. And so those are things to consider is, how does a family come into the room, and what do they hold with that? And what do people outside of them, what have they shown them about their child's disability? How often has a family gone to a park and their child had a meltdown, or their child maybe had mobility limitations that they couldn't be on the equipment in the way that the expectation was that a child should be their age, and a family looked at them? That all comes into the room when they're receiving a screening. So it's something to consider and to be aware of, is what's the family bringing in? Something else that we really just need to keep at the forefront, and I know this might come up in the Q&A later, is every single family that we spoke to right away said, will CPS get involved? When you are a parent of a child with a disability, especially, or a special healthcare need, especially if it's medically based, if at any point a child's life has felt threatened, I was talking to this mom who her child has cerebral palsy, and there was multiple times when he was young that she thought he wasn't going to live. She has a lot of fear around his life being taken or him being taken away from her, and that sits with her in every situation she moves through. So if a screening is being asked, has this such and such happened to this child? And in her head right away is, will he be taken away from me? Will my situation be intensified? And so those are things that we want to consider as a family comes in with that. Family said, first and foremost, transparency. Be honest about what your role is. Not in an alarming way, like I'm going to do this and this, but to be honest, and that's why sometimes the de-identified screening is much easier as a first step, because families don't quite fear as much, they don't, they might, and it's harder because you don't necessarily have all the information to make a very strategic referral. But as far as fear around CPS and will it intensify my situation, it's there. When you think about families having this intersectionality piece, that we hold multiple identities, I always have to keep in mind, historically, how has this person been treated by the healthcare community? When we think about generational trauma, we think about historically how a lot of Black community members were treated by the healthcare industry. I wouldn't want to share my information if historically there has been experimentation or things that have been done to the community and used against them. So it's things to consider. I think one of them, a really crucial question, and parents brought this up, around my experience. Families were willing to share what has their relationship been like with the healthcare community. So knowing and understanding, like, what's it been like with past doctors? What's it like now with your services? That was a big one. Is often I think sometimes we ask families, are you receiving the service? But we don't ask them, is the service working for you or not working for you? Gathering more information. And lastly, I'm just going to leave it with how do we normalize trauma? How do we make it comfortable? How do we reduce the stigma? Very simple things that we can say to families are, we all face challenges and we may need some extra support at times. It's about humanity. It's not simply about the family having a disability or special health care need, but it's about being our best selves. And so when we want to work with a family to support them, you know, what do you need? We all face things that are difficult at some times. I'm here to help you. Let's create a plan together. All right, thank you.
Karen, thank you so much. That was really excellent. But I think there's one thing that maybe the audience is not clear that you mentioned. You talked about ableism, and I'm not sure that the audience would understand what that is. So perhaps you could clarify.
Yeah, essentially ableism is, for the disability world, it's one of the isms. It's the discrimination that folks face in the disability community because they're not meeting the expectations that we place to be normal, which normal to me in its term in itself is an ableist term. It means when there's only a staircase in a building and someone uses a wheelchair, or not even a wheelchair, but someone has mobility limitations, that's a form of ableism because it's not set up so all people can thrive. Other ones are the judgment that I talked about. When we expect a child to behave in a certain way, that expectation, when a child maybe behaves has differing abilities or behaves in a different manner, the judgment that's placed, that's discrimination on someone who has a different way of being. So that's kind of in essence what ableism means.
Thank you. Shelley, there are a couple of questions for you that relate to hitting and how you can work with a family who discloses that they use corporal punishment with their child, and how you determine whether that requires a CPS referral or whether you can work with a family assuming that there's no significant injury or marks.
Sure, absolutely. So I'm looking at the thread here. And so one of the things, there was the first statement I saw is that teens who are completing the pearls are disclosing physical or psychological abuse at home, but they asked not that it not be reported. So I want to clearly state that we cannot hold abuse as a confidential issue. There is not a confidentiality standard with not reporting. So again, child abuse laws supersede all confidentiality standards there. So if a teen tells you that they are being physically abused, that is a mandated report. Now, the challenge is when we look at the other questions in this thread is really trying to understand the difference between disciplinary practices and physical abuse, child abuse. I think one of the arguments that a lot of groups have made is that there is not a great job in really helping to have a clear distinction between, for example, spanking and child abuse. So let's just take the word hitting. I think we also have to really spend a lot of time and understand, what does that mean for that parent? What does the word hitting mean? What does that mean that when the child says hitting? There's a lot of provocative words that different families, different cultures use when describing discipline practices, such as whoopings. And so a lot of times when I know there's some people who hear, this child got whooped or hit, it makes people go, oh my gosh, I have to report that. But sometimes we have to pause and really understand tell me more about that. Tell me, just like Karen said, tell me more about what does that mean? Tell me about what happens around that. And what we find is that what they're describing is spanking. Spanking is not a mandated report. I just want to make sure we're clear on that. Abusing your child, physical abuse is. Of course, also when you're using objects to discipline, objects to spank your child, there's a harm standard that you run the likelihood of causing harm. If we inflict injuries onto a child, then that kind of crosses the line of possibly a mandated reporter. But just because a parent says, I hit my child, just in that context, does not mean that's an automatic report. We have to ask questions. We have to really dissect that to understand what does that mean for that child and family. And, you know, if we have a family that we're able to talk about our concerns regarding that practice, then to be able, you know, and the family is engaged, then we can work with them to help them develop, you know, other kind of discipline patterns that might be more effective for that child that moves away from hitting. So hitting in and of itself does not mean a mandated report. And the same thing with, again, a teen who slaps, who gets slapped with a hand and a stick. Again, I think we still have to ask more questions. There was a landmark case in Santa Clara County, probably about 5 or 6 years ago, the case of the wooden spoon. And it was about a parent of a 12-year-old who was disciplining the child because of spanking. And the court ruled, in California that that was not child abuse because they had examined, you know, the greater picture of what was happening in the context of that discipline. So really kind of interesting. And there's a statement in there about kind of the no-hit zones. I'm on the board of directors for the California Professional Association on the Abuse of Children. And just like with other organizations, we are publishing out our policy statement in just another month or two on the no-hit zones. And again, while we understand kind of the science related to the issue of the adverse impact of hitting children or using that as a form of discipline, again, I still say we have to always preface it by understanding the cultural connections and everything else that happens with that. We have to understand kind of the context for different communities of color, especially the African communities. And if we go in right off of the bat and demonize this approach with a family, we surely will alienate, you know, a lot of our families in our communities. And that is not the goal. The goal is really to engage around, you know, developing healthy parenting practices.
Thank you, Shelley. That was really helpful. I would like both of you, maybe starting with Karen, to talk a little bit more about the confidentiality part as it from the parent's perspective. You know, there's a tension between trying to make sure that the team that takes care of a child and family all knows what's going on so that they don't have to, as Karen said, re-ask all the same questions and re-trigger. On the other hand, you know, what you put in a medical record that is, you know, potentially going to have a life of its own for, you know, decades possibly. And you don't necessarily know who is going to be looking at it in the future. How do you balance that? And how do you talk to families about that issue of confidentiality? Karen, could you start, and then maybe Shelley can also pick up?
Yeah, I mean, I think it goes back to that transparency piece. You do have to be honest if you're going to put something in a record with families. And families who were part of this project, I looked at a comment in the chat. There was a few that actually had really amazing experiences with their pediatricians, and that's what brought about some of the ideas. But their pediatricians were direct with them, and they had that balance of concern without showing alarm. And they said, you know, we're going to document this in the records because we want folks who engage with your family in the future to also know some of the things that you've been through. You know, this is not to be punitive, but it's to just let folks know that we want to provide the best care to help you be your best selves. And if we don't put it in here, folks don't know. And some of the things is this is saying to a family, if you have this capability to say, you know, this is what I'd like to write in the chart. Are you okay with that? Would you say it a different way? If you were to explain this to your child's next doctor, what would you feel it should say so that they know what your family's been through? And I think as a clinician, that's the best practice that I did when I worked with families was, what would you want your chart to say? And if I said it this way, does that sit okay with you? If not, let's talk about it. And I know it takes time, and time is challenging to have, but that would be where I would start.
That's a great idea. Shelley, what are your thoughts about the idea?
I would say ditto, especially as so many providers are kind of addressing the challenges that may come up with the Cures Act, and the visibility of our medical records. But I think that, one of the things that's really important, as Karen said, is just validating kind of a parent and a child's experiences. And so that's what we're doing, is we're acknowledging that these are very important, dynamics for, their overall health. We talk about how all of these experiences correlates to health, and that we convey that they are important to us. And so by us, figuring out ways to kind of put this in the chart, it helps ensure that we are mindful going forward of that child's experiences and what they might need in the future.
Thank you. I totally agree. And I think that Karen was very right in focusing on the 3 C's of continuity, coordination, and confidentiality. All those things are really important. I'd like we have just a few minutes left, but I'd like to just raise the question of how some of the COVID pandemic issues like social distancing and masking and so on might be impacting Karen's best practices about having the child be in another room, let's say, while you're talking about the child, or you're doing a telehealth visit and there's really not the opportunity for confidentiality because the child can hear everything that the parent is saying. So Karen, do you have any quick suggestions about how to handle those kinds of COVID-related things?
Flexibility. We've scheduled a lot more than normal. I've had to follow up with families and just say, is this going to be a good time for you? Do you feel like you'd need a separate space? Do you feel like you can get some time alone? But being as flexible as possible, it's been a big challenge. And we've had a lot of folks who are providers say we're seeing things that we didn't expect to see too on camera. And what do we do in that moment? So I think this whole pandemic has enlightened us to being extremely flexible, but continuing to ask the questions of what would make you most comfortable, to the family. If we're going to do a screening, we're going to talk about some things that I don't know if you want to talk later about it or if we could schedule something else, but really, I think it's about permission with families. It's about asking for permission and finding out if they're in the space that is most conducive, and it's not going to be perfect right now. Just like families are doing the best they can, we're doing the best we can in this moment.
And I think that advice is really important, because it's not like everything has to be handled at the moment, that you can always talk about how these are important issues and let's schedule another time to delve into this further, right? That's important.
Can I add one thing on there? I just would also just kind of say, one of the things I think we've learned that's really important is to kind of diversify our communication, the access that families have to, our parents have to communicate with us. So there are some parents that no matter if we reschedule, they still are not going to have a space and place where they can talk with us. So can we offer them a way to email us in our office if there are some questions that they want or things that they want us to know? And then perhaps we can kind of follow up with that later. There are offices who have been able to develop some text communication. So I think we've had to expand kind of how families get information to us, and that is just not going to be, unfortunately, this through the direct contact.
Well, I think that's a great point, and I think it's a two-way street, that sometimes we want to be able to provide information to families that not necessarily at the time. So on the issue of resources, we have sent a bunch of handouts that you can print to give to families that relate to some of these issues. All of them come from sites that have them in English, Spanish, and sometimes many other languages. If Nicole, if you could put up the resource slide, one of the things that we wanted to leave people with for in today's session is the concept that what we're really trying to do is prevention and early intervention. So we're trying to provide resources for families so that when they are feeling stressed, they don't know what to do, that there are various opportunities for them to be able to get help and information. And that could be, for example, the whattoexpect.com, which has free parenting support, such as handouts about losing your cool with your toddler. We have, for example, Family Paths that will that has various classes about positive parenting and parent support and fatherhood classes. There's a parenting stress hotline in both English and Spanish, so that parents could have that phone number if things get really dicey. And most importantly, there are the projects that are sponsoring this peer-to-peer training, which is the Medical Home Project that will provide information to the pediatricians, and the Help Me Grow hotlines that are for both Alameda and Contra Costa, that, for example, for the family that I led with the challenging case, the important referral would be to Help Me Grow, because they would then provide a family navigator who could then assist the family with getting both a regional center referral for the developmental problems about the child, but also to early childhood mental health to be able to work on some of the behavioral and emotional issues and the family stress issues that are going on. So we're very lucky that we have lots of resources in our community, but we need to be able to direct families to them. And as both Shelley and Karen said, provide supportive relationships with our patients and their families so that they can trust us with sharing what they feel they need or what is stressing them, and then we can direct them in the right directions. So Lorene, do you want to just finish up with what do's and don'ts about after the training?
Yes, absolutely. Thank you all so much for coming. And I just want to say that to please fill out the evaluation form attached in the chat, and also stay tuned for our next, hold on, peer-to-peer that's happening April 23rd. Yeah, which is Implementation Without Fear Part 2, and that's with Dr. Renee Martel. And we're going to be having navigating resources for children ages 0 to 5. So please stay tuned for that, and please register, and thank you so much for attending.